Okay, excellent. Thanks everybody for joining us for the final session of the day. It's been a long day on Zoom, but a very interesting one with a lot of facts and tips and strategies being presented. So thank you for sticking with us through to the end. I'm very excited today to have our amazing forensic nurses. One half of the amazing duo is here with us today. And so we've got Adrienne Forshaw, and I probably said your name wrong. I'm sorry, Forshaw. And Tiffany Kafka, here in spirit, our forensic nurse specialist from the Canadian Forensic Health Corporation. And they'll be today presenting an overview of the healthcare response to violence. So just briefly, Tiffany and Adrienne are directors of the Canadian Forensic Health Corporation, which is a corporation which houses one of only 2 accredited bodies in Canada delivering forensic healthcare education to physicians and to nurses. Adrienne has practiced since 2009, initially as a sexual assault nurse examiner, and then into generalist forensic services working with patients who endure domestic violence, pediatric sexual assault, human trafficking, and gender-based violence. Adrienne completed graduate studies with her final project on advanced examination for incidences of non-consensual anal rectal penetration. And I'll introduce Tiffany as well, although she's unable to join us for the talk today. She's been called away. Tiffany is a forensic nurse who is qualified in the Canadian federal courts to provide expert testimony on the topics of strangulation and interpersonal violence. Tiffany has dedicated years to the education and unification of community services to build a consistent multidisciplinary response to violence for Canadian communities. We did have a question earlier in an earlier session about expert testimony, so hopefully we'll see that question come up again and you can address it. But without further ado, I'll pass it over to you, Adrienne, to take it away. Thank you so much for joining us today.
Great, thank you. Hello. Thank you, Amanda, for that introduction. I am Adrienne, and I'm the co-director of Canadian Forensic Health, along with Tiffany Kafka. She does send her regrets today as she was called away specifically actually to court in the role of a forensic examiner and expert witness. Both Tiffany and I hold international certification in sexual assault nurse examination for adults and pediatrics, or it might be better known for some as the SANE A and SANE P credentials. I'm also a current forensic practitioner within Fraser Health, and there's a regional forensic nursing service, which covers a fairly large service area from Boston Bar to Burnaby. Patients looking to access such services travel either to Surrey or Abbotsford after usually being stabilized at the initial hospital that they may have presented at within Fraser Health, and medical concerns have been taken care of. I'm also a forensic healthcare educator with the Canadian Forensic Health Corporation. Tiffany and I both teach year-round forensic healthcare provider courses to physicians and nurses across Canada. And we appreciate actually Dr. McCormick inviting us to speak here. We're going to talk about the 5 W's, the what, when, why, where, and who of forensic healthcare. So we will cover overall what is this fast-growing science, and based off the science, how it is impacting the response to violence that we carry out in our forensic healthcare. So what is this fast-growing science? Well, historically, the sexual assault nurse examiner role emerged out of a recognized need that victims of violence who sought care for their injuries to their bodies in the emergency department required additional support. And often this healthcare documentation was then called to court. The process of the medical forensic examination evolved where forensic principles became quite foundational in a standardized, consistent, and systematic approach to patient exams. And this actually strengthened the information that was obtained during the exams in a way that aided law enforcement in their criminal investigation, as well as making the goal to make that information more palatable within the judicial process. Such services in the past were established specifically for patients reporting sexual assault. And you may have heard of that SANE nurse, which is a sexual assault nurse examiner who had specialized training to respond to the needs of patients who experience sexual assault. But as the old adage says, if you build it, they will come. Many services expanded their mandates to offer additional response to people who experience interpersonal or relational violence, specifically non-sexual crimes, such as physical assault associated with domestic violence, human trafficking, other incidents of abuse and neglect with a relational component. Included in the mandate is that most services will see victims within a few days from the incident. forensic laboratory processes have evolved, and we're seeing the science that the window of time to see patients or provide this medical forensic exam is actually growing. And we are up to about 7 days post-event, where it is still viable and useful to do a medical forensic exam to gather not just information about body injuries, but specimens for DNA. Further to this, the forensic nurse or physician examiner is there to offer the patient, with the patient's consent, this medical forensic exam that is going to look over the patient's body. I always explain it as kind of 3 head to toes with additional focused assessments that look for visible as well as non-visible injuries in a manner that's objective, neutral, unbiased, and in language which is quite understandable to non-healthcare individuals. So we stay away from medical jargon. And that enables police or other people investigating the crime to use this information quite swiftly with the patient's consent in their investigation. A Crown carrying forth a charge, or if a trier of fact, will also find the information usable in the court case. When we talk, one second, please. Whoops. Sorry, I've got one dog. Sorry.
Surprised I didn't set mine off. He's definitely listening, but not reacting.
I should have put it out. So sorry. Now, actually, this was a time for you to read anyways. What do you think about this statement? True or false? A medical forensic examiner is required for all patients with visible injuries after interpersonal violence. It's false, because patients with non-visible injuries require a medical forensic exam as well. And we do have the evidence to support this. These examinations have expanded to include added components such as the assessment for traumatic brain injury. Strangulation has continued to change what we screen for. In fact, the findings of these exams have paved the way to change society's views in the laws. We've evolved technology and crime lab procedures to be able to require a very small sample of DNA for use in investigation. And the evolution of sample testing has also led to these larger windows or timeframes to collect information from the patients. One such study actually was completed by Pat Speck, where she recruited consenting couples to engage in penile vaginal penetration. And then the female participant had their vagina swabbed each day to see if the male partner's DNA could be detected still. Do you dare to hazard how long out male DNA could still be sampled from a vagina? Very important research, because what we found for some individuals, and there were many factors that impact the finding, but that up to 30 days, male DNA could be detected. Finger in touch, just contact, touching an anus, and we'll say a finger inserted into an anus, detection of DNA sampling can occur 7 days post-incident. And that is omitting many factors, such as how many times the patient washed, how many times the patient had bowel movement, had wiped. Their majority, there was a significant finding of 7 days post. The message here is that the science has evolved, and so that we have better tests and more sophisticated processing that allows specimen collection to happen days after the incident. In the case of traumatic brain injury, the forensic healthcare provider may detect either traumatic brain injury from either blunt force injury or strangulation because the way the patient presents. The clinical findings can be very similar. Specifically during the sexual assault exam or the forensic exam, we are seeing that in the context of sexual assault, clinicians are asking about or screening for traumatic brain injury 12% of the time across North America. That's actually a predominantly American stat, but our standard services across the United States had indicated in a survey that the screening is coming. It is growing in statistics and in practice, and we are hoping with the research that even Dr. McCormick has put on today that we see the value in making sure these screening processes become a standard in all services. Providers should ask for mechanism of injury, and they will document the history associated with reports from the patient around the incident. And once it's determined that pressure was applied or there was a blow to the head, forensic examiners will look for signs of brain hypoxia. And I know you covered many of this content today. I don't mean to go through different scales of determining traumatic brain injury, but I do want to stress the importance that in the medical forensic exam, this information can be very useful in the court process. So for example, when we are screening for brain hypoxia and the patient says yes to certain subjective questions, we'll move on to brain anoxia questions, such as, did you lose consciousness? If the patient says no, they did not lose consciousness, we will ask questions based on the previous symptom that they reported that signaled brain hypoxia. So when they said, well, I don't know, I never lost consciousness, I felt dizzy, we will ask questions around that dizziness sensation. And usually our patients are not great at recalling specific details related to the dizziness symptom. They may have a memory gap, and that memory gap is consistent with a loss of consciousness. In fact, this is not new research. It's research we've learned over many years. The Rosen study in 1943 was a group of scientists that studied strangulation in patients. It came out of actually the World War II, where US fighter pilots were diving down their planes to drop bombs very, very fast. And when they pulled up, the G-force was actually leading to many of those pilots passing out. So scientists were kind of contracted to figure out a way to stop that from happening, stop them from passing out. And through the research, this was before the IRB, but before the research, with that research, they went into a prison and had volunteers volunteer to be strangled and to pass out. And what they found, the outcomes of that study, was that several patients, even though they knew they were signing up to be strangled until they passed out, many of those volunteers or subjects denied an LOC, even though objectively it was observed they were lost, there was a loss of consciousness. Many patients not remembering that loss of consciousness is the outcome of that science, is understanding that a memory gap can be consistent with that LOC. And that has led to practice today starting to change, where emergency departments, some are even have stopped asking that specific question, did you lose consciousness? It can be useful information, so I'm not suggesting we totally omit it, but not to use that as the sole qualifier, as thinking that absolutely that event didn't happen. And especially if we're screening for patients who don't remember that event, we could be missing traumatic brain injury. And it is quite interesting. There is a study that's going on right now that is finding that traumatic brain injury in interpersonal violence is being missed 4 out of 10 times, 4 out of 10 cases. That is quite significant. When you think about, as an emergency nurse, if we were missing 4 out of 10 strokes or 4 out of 10 heart attacks, I think people would be up in arms. This is the same. This evidence is coming to us to be able to provide us the necessary information to ensure that practice changes and that we are documenting the findings, and we're using this evidence to speak to our findings in the courtroom. No one has studied yet actually how often the victim of sexual assault experiences traumatic brain injury, but I do anticipate that will be another change that we will see in the future, although there are some challenges around that type of research. But you can see how much this will now support practice. So who does this practice? Who is the forensic healthcare provider? Forensic healthcare provider, well, some are doctors, some are nurses, some are nurse practitioners. But what do you think of this question or this statement? True or false? The forensic nurse examiner cannot detect injury to the brain that is consistent with blunt force trauma. It is false. And I'll speak to that, but what I want to highlight here is that whether you are a nurse, a physician, or an NP, all have the same specialized training to provide medical forensic examination for people who experience violence in the context of sexual violence or domestic violence. A medical forensic examination is this process that is done by a forensic examiner, and it's followed the exact same way every single time. It's guided by forensic principles and involves the collection of specimens, the identification of injuries, and the documentation or photo documentation of those injuries, as well as screening for non-visible injuries, such as those which occur with strangulation and head injury. When screening for traumatic brain injury occurs during the medical forensic exam, whether it is a nurse or a doctor or a clinician of what sort, they have to have the same specialized training. It's expected they know the same things in the context of forensic healthcare. They read the same studies, they apply the same research to practice, and even more, the outcome is they will testify the same in court. The big difference is diagnosis. Whereas the RN cannot diagnose, they still do screen for traumatic brain injury, and they may speak to those findings in courtroom testimony. Forensic healthcare involves processes where, through informed consent, the patient provides the examiner the consent to detect, identify, and assess for these type of injuries. It's unreasonable. Many of these exams can take quite a few hours. I would say a standard exam for Tiffany. Tiffany's a little quicker than I am. She can usually move about 3 to 4 hours through a standard exam, and I'm still about 4 to 5, maybe even 6 for the norm, the average. I'll put 5 hours is kind of the average. We have time in our medical forensic exams to screen for non-visible injuries. It's unreasonable to think an ER doc is going to spend these type of hours with a patient to render a patient with a diagnosis of TBI. But in a medical forensic examination, to screen for it, we have the skill set to do it. Nurses stepped forward in the 70s and 80s to testify in regards to injuries to the vagina that's consistent with a history of sexual assault. We testify to injuries to the head and neck that are consistent with a history of strangulation. And a nurse or clinician can go to court and talk about injuries to the head and brain that are consistent with blunt force trauma. So why then should the medical legal management, or this process, involve other people or other members of the multidisciplinary team? This is a very important point that I will highlight here. The multidisciplinary team is an approach that we acknowledge the sequelae of events that are associated with a traumatic incident or violence and interpersonal violence leads to both short-term and long-term outcomes. And some, if not addressed or supported appropriately, can have negative outcomes. There's a lot of training that goes now into the neuroscience of fear or fear reactions. Though not well understood, a forensic examiner will often speak to that patient demeanor or presentation in the courtroom because we understand the variability of presentations for complainants of interpersonal violence at the time of the exam, and why it might be difficult, for example, gathering information about the chronological order of events. We know through the neuroscience or neurobiology of trauma that it's unrealistic to think the hippocampus has filed those memories in any sort of order. And it is consistent with actually a traumatic event or a traumatic experience. The multidisciplinary approach then understands that based on the neural processes needed in order to make sense of this event and move past it or move through it actually is more appropriate, we need a multidisciplinary approach so we can customize the needs or customize the response to the needs of the patient. It is not correct to say with traumatic brain injury, the only aspect that's affected is physical. There are social, emotional, economical impacts. There will be legal outcome changes, and it is essential to have all of our multidisciplinary agencies working together to provide this support for patients moving forward and in the long-term sense. So when you think specifically of the forensic healthcare practitioner, are we victim advocates? No. I think I've got mostly false so far, if you've caught on to a theme. We are forensic healthcare practitioners are advocates of the evidence. They are advocates for the evidence that we collect during our medical forensic exam. We are advocates for the healthcare of our patients, regardless of that patient's status in the cycle of violence, be it the victim, the suspect, the accused, the perpetrator of the violence. We treat these patients as patients, period. Forensic healthcare practitioners are utilized as expert witnesses, such as Tiffany today, by both prosecuting and defense attorneys in the pursuit of justice. We are used by both sides. Both lawyers will access us. We have specialized advanced training and experience and expertise to be able to explain the occurrence or absence of visible injury, as well as the signs and symptoms relevant to the incident, in order to aid legal counsel in the interpretation of findings in the medical forensic record and the mechanisms of injury on the human body. Effective testimony is provided in an ethical manner. It serves to educate the courtroom, provides education that's necessary for the trier of fact to arrive at a just decision. Effective utilization for forensic healthcare practitioners as expert witnesses have been demonstrated to support not only more favorable judicial outcomes, but also favorable and just outcomes for patients and the multidisciplinary team. So when should forensic healthcare, when is it required? When should you refer patients? When does a patient need that intervention? Well, one of my few, actually this is a really good one. True or false? Forensic healthcare services are required whenever the police want a physician to complete a rape kit. So police do not determine if a rape kit is done. Police may ask the patient to come to the hospital. Police may request the consideration, but it is not at the request of police that this is being forced upon someone who, and we will talk about a little more kind of about that. It's done, first of all, at the request of the patient. It is the right that is, the medical forensic exam is only done with informed consent. All people in Canada under Section 7 of the Charter of Health and Rights and Freedoms have the right to personal autonomy and bodily integrity. This right means that patients can make choices in regards to what's taken from their body for legal use. Of course, this is different for suspects or persons accused, or when a warrant is obtained. This goes kind of beyond the covering of what I would like to cover today. But the point here is to understand that it is with consent of the patient. So forensic healthcare operates under informed consent and not under the law which governs implied consent for healthcare. So for example, an unconscious patient found down in the community, ligature marks around their neck, contusions to their head, they may require intubation. A healthcare provider would do this without their permission. They would do this in order to sustain life. Whereas a healthcare provider would not perform a medical forensic exam until the patient was awake, alert, and provide informed consent. It is up to the patient to decide if they want that information taken, have injury documentation, have photography done to their body. Patients should not only have the choice, but it is their right, sorry about that, it is their right to be able to access this service. They should be able to access this service without barriers, no matter where their geographical location is. In fact, the idea of a rape kit is quite inaccurate too for cases such as interpersonal violence, because physical contact might occur with no sexual contact, and a medical forensic exam can be still indicated. Information is gathered from the body, which would include injury documentation, such as details about the ligature marks to the neck. Those details would be quite detailed, more so than what would be the standard collection of information in an emergency department, like in that trauma room as they're intubating. The information would talk about the pattern, the depth, the size, the distinct or the correct measurements, exact measurements of the injury. And all this detail speaks to the mechanism that was employed. So this medical forensic exam takes information like specimens, documentation of photography, and it should be labeled as such. Rape kit is not accurate. There are internationally established guidelines which govern this medical forensic exam practice, as well as forensic healthcare providers. Another thing that I did feel quite essential to mention here is that the World Health Organization has a document which speaks to the forensic principles involved in the examination, one of which is essential to know: healthcare comes first over forensic evidence collection. I've talked about the science providing a bigger window than many people do believe when it comes to gathering that evidence. Whereas healthcare, especially interventions to sustain life, we don't have those type of timelines. And so fundamentally, healthcare comes first over forensics. This is so fundamental that it comes up frequently in court that lawyers will argue if medical care did not come first, resulting in that evidence may result in being inadmissible, not usable, because if that evidence was collected at the expense of someone's health, it is now perceived to be biased. It's not neutral. The intention was not objective, neutral, and without judgment. So making sure that we have the patient's consent, making sure that it is done in an objective, neutral manner and done in appropriate timelines where healthcare has preceded is essential to this care. Can patients then, if they are so seriously injured, like that example I gave, where they've found down with ligature marks, they would know surely that that's injured. Can patients ever be seriously injured and not know that they're injured? It's true. This is actually, Tiffany and I use this as a great example of how patients can be seriously injured and not know they're injured. Tiffany uses this in our strangulation education. And this was from the Strangulation Institute. This is a picture of a patient who presented 6 days post-strangulation. What are your thoughts? Can you see bruises, marks, looks really beat up badly? Often, trauma in strangulation, we don't see visible injuries because the amount of force is required to create injury on the outside of the body is greater than the force required to create injury on the inside. Half the victims we see will not have any sort of visible injury. And if they do have visible injury, out of that 50%, 15% will actually be photographable, even in fatal cases. So that picture is on the same day this patient went for a CT of their neck. And this is their CT. It shows a bilateral carotid artery dissection, which could be fatal 6 days post-event. Essential information to understand when a medical forensic exam should be done. This should be done after medical care is stabilized, but also it should be done, period. And patients do have a right to access this care. Where then should this care be done? True or false? The most effective care models for patients affected by intentional violence are always in emerge departments. False. There are many reasons why hospital emergency departments may not be the best model of care for the patient experiencing intentional violence. Patients themselves have identified their hesitancy to go to the hospital. The emergency department itself is a chaotic environment. Oftentimes there's numerous people around in the waiting rooms, the sounds of beeping, people crying, yelling, screaming. This can all heighten the anxiety of a person who's already in a traumatic situation. And persons who have experienced violence may have to repeat their story several times to several different people. They also may find that they won't find it. They will wait in emergency departments. They will wait to be seen by a triage nurse. They will wait to be brought back into a room to see a doctor. They will wait to have lab tests done, and then they'll wait for some imaging. They'll wait for social work, and they will wait for a forensic healthcare provider. So in addition to the patient's hesitancy to go to the emergency department, we have barriers in our healthcare system itself. And then that's really that our emergencies are overburdened. They're understaffed. The healthcare as a whole is seeing a shortage of healthcare providers. Specifically, nurses are leaving the profession altogether, and the staffing shortage is really reaching critical levels. We're seeing the possibility of permanent closures of emergency departments in the Northern Health region. That doesn't mean here in Fraser Health we're immune. Recently, we have seen temporary closures of many emerge departments due to staffing and COVID outbreaks. So within the province of BC, there are about 60 currently practicing forensic healthcare practitioners. And those are the ones that have the education, training, experience to conduct these medical forensic exams. Of these 60, 14 have gained internationally recognized certification in their field of practice. Tiffany and I both hold that certification, as well as there's 4 that focus specifically on children across BC. And again, Tiffany and I are 2 of those 4. So in addition to the limited number of adequately trained forensic personnel, there's limited access to forensic healthcare training. In Canada, there actually are only 2 entities, as Dr. McCormick talked about earlier. We have 2 agencies that have the international accredited curriculum for specialized nursing education and physician education. Both here are in BC, that's great, BCIT and Canadian Forensic Health, but these are definitely impacting accessibility to such service. And current forensic healthcare delivery models
It was never sent to me, so
are limited.
they're both thawed. Everything's ready, so when you decide what you want to make, it's all there. Sorry.
That's okay.
There are 4 hospital-based forensic nursing models operating out of emergency departments, Nanaimo, Victoria, Surrey, and Abbotsford. And there is a blended physician nurse model that works at a BC Women's, well, actually out of the emergency department at BGH. And the Interior actually has just received funding to develop their forensic healthcare response within their health authority. Looking at how it's always been done is no longer an adequate approach to anything, especially the medical forensic response to violence. The most recent global pandemic has taught us to think outside of the box. Virtual learning become a commonplace. Working remotely has been shown to be successful in corporations, even when your dog's barking in the background. Access to healthcare services have experienced innovative solutions such as telehealth. We're doing forensic exams over telehealth. We're moving some services to the community setting. We know better, so we can do better. And that is something, knowing we can do better when we work together as a multidisciplinary response to address this violence in our communities. We are serving benefits in a number of different ways. We are incorporating forensic healthcare into this response. It relieves the strain on an already overburdened acute care system. Secondly, the services are, when the services are available in one place, one-stop shop, this delays, or this stops the delay in referrals, and it all actually results in better outcomes for patients. They can get the help, the customized help they need. Research over the past couple of decades has shown that a fully integrated multidisciplinary team response in the community is the way to go. We see this emerging in the United States. We're seeing some coming out here in Canada. And a fully integrated localized multidisciplinary response enhances communication and collaboration to achieve the best outcomes for everyone. So what do we find for integrated community models here? Well, there's one fully integrated multidisciplinary team here, and that's in Victoria. In this model, patients have access to forensic healthcare, victim services, police, legal counsel. Their scope, however, is limited right now to sexual assault only. There are a couple of other community response models in development in the Interior, the Lower Mainland, and in Vancouver. There is actually also several child, youth, and advocacy centers who are looking to include forensic healthcare in their multidisciplinary models. There are several fully integrated multidisciplinary team models throughout Canada, and we do see Abbotsford actually is perfectly poised to become an exemplar community to house such a model service to address intentional violence. We have an excellent IPVU in the Abbotsford Police Department. We have dedicated Crown Counsel, and we have a variety of amazing victim service providers and an incredibly collaborative Law Weird Committee. So together with the ongoing research at UFV in intimate partner violence, the Abbotsford community has an opportunity to become a leader in the province. So this is the overview, hashtag forensic healthcare. It's no longer a hashtag, it is a practice, it's an established practice, and there's a lot to be built on upon this foundation. The 5 W's of what we do is presented here, and I've just included some of our practice partners where some of the information that I shared today came from. I am very proud to do the work I did. I hope my passion kind of came across, but I hope more importantly, some essential components of the forensic healthcare response sits with you well, and that you will see where we go from here in continuing to build this response. If you have any questions, concerns, please email us as info@canadianforensichealth.com.
Thank you so much for that. That was really helpful to understand sort of the big picture. And also I feel like you issued as a personal challenge to get going and develop this collaborative multidisciplinary team in Abbotsford. So I know a number of the Abbotsford reps are here, and I'm sure that we will accept that challenge and do what we can with it moving forward.
Wonderful.
I'm just going to change the view back to gallery here for a second. There we go. I did have a couple of questions, but first I wanted to see, of course, if anybody in the audience today wanted to pop a question into the chat box or the Q&A or raise their hand, and I can unmute you. So we'll just wait a moment to see if there's any questions from outside. I know we had a question earlier. Oh, okay. So Lisa's got a question. How often on average are you testifying? And also, can I add to your question, Lisa, whereabouts are you testifying? So are you going in this full geographical range, or is it primarily in like a particular community, for example?
No, we see, we testify based on both providing testimony as an expert witness or as a fact witness as a result of our medical forensic exam. So I have testified as far out as Nova Scotia, providing opinion on an incident that had occurred. I've also testified locally, and yes, because Fraser Health spans quite a large area, I've Surrey courts. I actually was scheduled this end of this week for a Chilliwack case, and up next week for a Surrey case. I believe Tiffany's and another jurisdiction. So we go to where it's needed, and because Fraser Health covers a large geographical area, but we tend to try to house our best practices that patients come to one of two locations in the region. That means we travel to go to the appropriate court. How often? I don't want to say, well, I don't think we testify often enough given the numbers that we see. So we are not seeing, there are a number of cases that occur in a year, and I wouldn't say a large percentage are we testifying. I have rough stats, not specific to Fraser Health, but in general, that of the 100%, and we'll use sexual assault stats because that's where we have stats from currently, consistent ones. Out of 100% that happen, 50% get reported. And we know of that 50% that get reported, I'm talking more presenting to emergency departments, telling a friend, calling an ambulance, you know, first responder type situation. It shrinks down, and we see that shrink kind of in regards to the approach that those first responders may take with the patient, shrinks down to actually about 12% getting charges applied, charges laid. And out of that, about with the evidence and whatnot, 2% being actually through a trial and a conviction. So that's a pretty, like, out of 100%, we're going 2% of the time. 10%, 10% I think is a rough number where we are entertaining a trial. And when we do go, I would say more and more, we are being used as expert witnesses. So it will not just be, yes, I saw that bruise on the neck. We are testifying to the mechanism of the injury, and if that is consistent with, if that finding was consistent with strangulation or consistent with traumatic brain injury. So we're being used differently. We still don't go equal to the number of cases that we're seeing.
And Lisa had a follow-up question, a great question. Do you testify outside of criminal court? So for example, in family court or in private litigation?
I personally have not. And I don't see, now going back to the ethics around it, and it's the same thing when I talked about, we are advocates for the evidence. We're advocates for healthcare, and we're advocates for the outcomes to be positive for all, but we want justice to prevail. So when I go to court, I'm often educating the courtroom about information from that medical record or that medical forensic exam, which is housed outside of the medical record, I should say. But when it comes to actual outcomes, I don't see, what do I want to say with that? When we do go to court, we are usually in criminal court. I don't think we're usually in provincial or supreme. We are not being used consistently in like private litigation or other charges. I do find one thing, we do work closely with MCFD, so we will be involved in situations, but again, only when criminal charges are laid are we being used in family courts. So we do see use of our services, in those situations, but we are not usually having to testify there. Having said, I will add one piece though, is we do these exams on suspects, and not so much with the suspect's permission. So it's kind of irrelevant to us who the patient is. Somebody who has encountered an instance of violence, interpersonal or relational violence is our mandate or prerogative. We will do a forensic exam, regardless of who's accusing who.
I don't know if you can answer this question, but we've had this new criminal code for 267C for assault by strangulation or sexual assault by strangulation or choking. Have you seen an uptick in requests to testify about the effects of strangulation since this has been introduced into the legislation?
I can't answer it. I can answer it anecdotally. I cannot answer it actually. And I wish this would be one for Tiffany. She truly is one of our provincial specialists. But I would say, yes, I think that's consistent with us going to court and more testifying differently. Instead of testifying as fact witnesses, we are being added to that. And we know that the information, often even in pretrial interviews, that education for the lawyer to say, this is what that means, that finding, the fact that there was a memory gap is consistent with a traumatic brain injury, is oftentimes that will flag lawyers to go, well, we need you to be an expert then in this, not just to give the facts. So we have seen this practice definitely play a role in the impact of the outcomes in the judicial system. And I would say specific with strangulation, we have seen that pivot. We're a part of the puzzle, but a small piece, but I think an essential piece to finally get to a place where we recognize strangulation not to be physical assault, but may lead to charges of attempted murder, because we understand the sequelae of events that occur with traumatic brain injury. We understand that bilateral carotid dissection, despite a normal presentation externally. So all of that information, yeah, we are seeing that we are testifying as experts more often because of it.
We sort of talked about this earlier about, the challenge of increasing the awareness around issues like head injury and strangulation, but then not having the available services there to refer people to. So we've detected this issue, but what can we do about it? We either can't refer you to anyone because there's no one local, or we can refer you, but you're going to have to wait, 3-6 months before you get in there. So I guess that's kind of like a double-edged sword in a way, right? You have this potential issue of being called on too much to provide this testimony going forwards, given the increasing understanding that we're having around these issues. So I don't know if there's a solution for that, but more practicum students, hopefully, going into a career in nursing.
More accessibility. If there's anything I can encourage that takeaway is just the accessibility piece for this type of healthcare is really important across our province.
Yeah, I had a question, but first I wanted to follow up. Lisa had one earlier. I don't know if you still wanted to ask it, Lisa, but it was about how often are cadavers, examined for evidence of strangulation. I don't know if you know the answer to that or not.
I would say, because my specialty area is with living forensics, living bodies, I don't go near that. And that's just, there are definitely in this practice people that do death investigation, and I have focused solely on the living, so I cannot comment.
I imagine it's missed in a lot of cases unless there's a specific indicator to look for, because it's not something that there's obviously visible injuries on the outside all the time, but there will often be some on the inside. I'm waiting for other questions from the audience, but while I do that, I did want to ask you about a statement that you made towards the beginning. You said, I believe it was that traumatic brain injury in intimate partner violence is being missed 4 out of every 10 times. That's the research that's ongoing right now. Is this because the questions are not being asked that need to be asked, or is it because they're not being asked the right way?
So number one, actually, it's because of the fact that visible injuries or patients with visible injuries are being referred for examination, and people without are not. So number one problem is that everyone should be coming for a forensic exam, medical forensic exam, after an event or incidents of interpersonal trauma, interpersonal violence has occurred. So number one, we don't need visible injuries. Number two, if we are talking about with regards to the 4 out of 10, it is the style in which we're moving through our examinations. And as we now learn or properly apply the science, because the Rosen study was in 43, but we are kind of looking at our science. We're seeing that because we don't need the injury to be there, we're kind of going, well, what are we missing? And so that 4 out of 10 has to do with whether or not we're screening in these exams. And that's changing what our medical forensic examination entails. For the longest time, actually in the last decade, I never screened for traumatic brain injury or strangulation. I asked what happened. They gave me a little bit of a report. I did my standard, and this was because we originated out of sexual assault. We wanted to know, was there penetration? What type of penetration? What was visible to the body? Were there bruises? Were there bite marks? Were there, and we don't call them bite marks, but was there any, what sort of information was on their body? And that was it. And I would say it's in the last 5 years that we have seen services, as few that there are here in BC, we've changed our charting to start implementing these screening for these situations, and pushing back on our partners in the community to bring those patients in, even when those visible injury, when there's no visible injuries. Mm-hmm. So a few things that are leading to hopefully that 4 out of 10 starting to climb.
Yeah. I talked a little bit about the Embrace Clinic earlier and had it up on my slides over the lunch break. So people working in the Fraser Valley region or close to the Fraser Valley region, what would trigger them, or what should trigger them to recommend a referral to somewhere like the Embrace Clinic to go and have an assessment done for these kinds of issues? Is there anything that stands out, or anything they should be asking that might then lead to that referral to happen?
I think it's the screening. So there are actually a lot of, if we're talking specifically in the context of healthcare, there are quite a few good, I think it's the Shasta. There's a few different types of tools that exist out there to kind of lead us through that line of questioning, to raise that index of suspicion. For us, I would say 9 times out of 10, at least in BC, it's the initiation of a medical forensic approach, whether that be by a doctor in one of the Northern Health hospitals, whether it be a trained nurse out of Victoria. Whoever's doing that initial response would recognize that with this event, all of this multidisciplinary follow-up should occur. And yes, Embrace being in Surrey, there's quite a few different ways that we are following up, but so long as there's multidisciplinary access. And I would say we have a lot of our partners at the tables doing really, really good information and sharing, but we're not yet established in a working together in practice type scenario. So I think that's our next chapter, to make a better response and better follow-up and better treatment and accessibility to this all, is by us connecting, and likely in the community, over an acute care sort of response. There's certainly a place for emerge departments. I've belonged to one for almost 20 years, but we just know that some people never go to emerge. So we do, and once you are stabilized, you're no longer needing to stay. We need that community existence of a structure that will be able to better address patients' acute and long-term care needs in one spot. Yeah,
the one-stop shop idea. What are some of the reasons why? So if somebody is referred to a forensic nurse to have an examination done for whatever reason, you mentioned before about, they're not all going to go. What are some of the reasons why? Like, what are the major barriers when somebody is referred to a forensic nurse to have an examination done, that they choose not to consent to that exam happening? Do you know what those barriers are? Like, what are the main reasons why they're not wanting to proceed?
Usually it's the opposite. It's the accessibility. So I would say and actually I will do that from my perspective in the healthcare system. There are certainly, I know there's a lot of times that patients don't come. I do realize that. I think one of the big pieces is being housed in acute care is a barrier in itself. People, especially through COVID, our numbers, nobody was coming to the hospital because that's where the COVID is. So there's situations where in acute care, we are finding people simply don't come. But when they do, and they have access to such a provider with this expert training, and there's an informed consent process, that in itself empowers any victim of crime, and giving them the choice to say, we can have information taken from your body. Would you like that? I would say opposite with what you're saying, kind of thinking about people not coming. It's the style and the manner that the exam is done that usually patients choose to have this exam. Another barrier, though, is accessibility to it. So not just in emerge departments, but just geographically to a provider. Not all emerge departments have a forensic healthcare service. Not always, even when there is one. Another interesting thing is we will have people calling our departments going, is anyone working tonight? Do you have someone on call for a forensic exam? And the answer should never be no. Of course we do. We have a healthcare provider. Someone can come, you can come in and we can help you. The accessibility piece we will figure out, but I know that sometimes, again, I think it relates to non-visible injuries. When a patient has no injuries, police will call and say, do you have anyone on? Should we come tonight? And quite frankly, it's a good question, but our answer should always be, yes, you come tonight, because we can start that process. We can start that follow-up. We can do those connections and those referrals to the community. Even if that medical forensic exam doesn't happen tonight, follow-up can be arranged for it to happen. So that would be a strong message, I would say, to our community partners to encourage the pursuit of it, especially here in the Fraser Valley, because we have the services.
So if somebody is out in, let's say, Hope or Agassiz, for example, and they want to connect a client that they're working with to those forensic services, geographically, right, they're going to have to get out there somehow, right? You don't have the ability to just pack up and move and go out to where the services are needed. They have to come to you for those services.
Right now, yeah. Again, so that's like, if I keep turning a page in the perfect future and the utopic future, we are looking at mobile services, and that is something that's actually Nova Scotia operates with a mobile service. Ontario has a mobile service, so it's doable. But there are additional pieces to that, because again, transporting evidence, protocols, policies, safety are all pieces that down in the States, they've had situations where nurses were driving back with evidence and were assaulted themselves on the roads and stuff. So there are challenges associated with having that provider just go anywhere. And but there's not the necessity of having it one-stop shop. There's some good points to best practices that happen with a person coming to the service, and there's certainly increased accessibility by us going. I would say there's people on the island currently that running services, more the North Island, where telehealth has really been amazing to guide a healthcare provider, but have the additional forensic expertise just to kind of say, okay, if you do that, make sure you do the swab this way. If you drop the swab on the floor where it's not usable, let's do another, like just to embed those forensic principles into the exam, because healthcare providers were originally great for this and continue to be. It's because of the emerging science that now it's there's a lot to know and a lot to be able to appropriately speak to in the courtroom. And that's where I would say it'd be nice if we all could just have this forensic education and training. That would be, again, ideal, but we do have access to it. So either through telehealth or a mobile response in the next chapter would be a lovely idea.
Yeah, great. Good to hear that that's already being discussed. And are most of your referrals coming from police, or how many like self-referrals do you have? How many from victims, like community-based victim services, for example, shelter, transition homes? Are you seeing those larger sources? Yeah,
if you build it, they will come, but and that means all the people you mentioned need to know about it. Yeah. So I say it's not just our responsibility to educate the courtroom. It is also our responsibility to educate our community providers. So this is not something that people should just know we're here. We do go out and do a lot of education, hence our presence today. But we want people to know that this has kind of this practice has emerged. We've blossomed between the healthcare and the legal realm, and there's a better way to respond to patients that really empower their future of moving through their trauma. And so I think that we have it on ourselves that we do enjoy, actually, and for any of our community partners here today, if you're looking for more information, we do often go out shelters and victim services, police departments, a lot of the watch commands, we would do like a quick kind of in-service just to educate around these principles and why you would come. When do you come to us? When's appropriate? When's it not? So yeah. Please contact us.
I will ask you if you can just pop into the chat box again, your email address, the best way for people to contact you. Because that was going to be my next question for anybody who wants to maybe potentially start referring people over to you for these kinds of services. What's the best way to reach out to you for that connection? Please. So through the email, best way to reach you? Yeah. Excellent. Okay, are there any other questions from the audience? I've been dominating the chat a lot today, and I have access to Adrian outside of today, so I'd like to open it up to anybody else who might want to ask a question in the Q&A or pop a question into the chat. Anything else that you burning desire to know or need to know? You can hear my dog snoring in the background. He's been very tired up from today. Okay, it looks like we don't have any other questions, but I just wanted to thank you so much for today and for that very informative presentation. It's always great to spread knowledge about the resources that are available in our local communities, what you do, why you do it, how you do it, you know, where you do it. All of that is really, really helpful information to have. Also just mentioning as well, the theme of empowerment has come up a couple of different times today. So, you know, putting a survivor in contact with somebody who can do an assessment, who can give them some information about what might be going on inside of them. You know, having these questions and screening done around brain injury was also mentioned as being a very empowering moment for someone to understand why they're struggling the way that they are. I think if there's one theme I'm going to pull from today, it's empowerment. And the second one would be education. So I think this has been a great day for achieving those two goals. Thank you everybody in the audience as well for attending today. It's been great to have you here. If you do have any follow-up questions for any of the presenters, each of them have put their contact information up either on their slides or in their chat boxes. So feel free to reach out to them if you have any direct questions that you would like to ask them. But also feel free to reach out to me. I'm happy to put you in contact with any of the presenters from today so you can ask those follow-up questions. You will all be receiving an email from me as well. You should have already. A pre-survey email that I sent out asking you to please share a little bit of information about what you were looking for in the workshops. I will be sending out another email pretty soon after today, after this event, just asking for your feedback about how everything went. What stood out for you in terms of the key lessons? What else would you like to see going forward in terms of future training opportunities or education opportunities? I'd like to also measure any changes in knowledge around brain injuries. So you'll be getting that survey link today. And if possible to fill it out, it'll take you maybe 5 to 10 minutes, but there is of course the consent process. So please make sure you read all the information and send me an email if you have any questions about the feedback or about the event today or about what we're trying to do with the research. Thank you, everybody. I'm seeing some comments in the chat box. So thank you all for being here today. And we look forward to providing some future education and training opportunities going forward. Thanks so much. Thank you again, Adrian, for your talk today. Very, very helpful. All right. And with that, I guess we'll wrap up early today. So go out and enjoy your extra 15 minutes of sunshine. Thanks, everybody.